Welcome to our studio here in Leeuwarden, the Netherlands, and welcome to this invitational webinar on the need for innovation on renal replacement therapy. A side event of the annual Congress of ERA-EDTA, the 57th edition, and by far the most special one, because never before have we not actually physically come together for this Congress, but are we spread across the world in different time zones to talk about the need of innovation and the future of people with chronic kidney diseases. And today we are joined by mostly people from across Europe, but also from across the world. We have people from the US, Canada, Singapore, Japan, and maybe even some other countries from outside Europe that I now forget to mention. Welcome and a very good morning or good evening, wherever you are. Good to see you in today's session. The World Health Organization described chronic kidney disease as the most neglected chronic disease and a growing burden on the European health, well, the world health situation. And therefore, a group of organizations decided to join forces to look for innovation. And these organizations are the Dutch Kidney Foundation, ERA-EDTA, and the European Kidney Alliance. They've joined forces, and today is a kickoff in the search for innovation in Europe and worldwide to find a renal replacement therapy in Europe, but also worldwide. In today's program, we are going to take several steps between now and 4:45. First of all, we are going to look at the need for change. After that, we'll be looking for inspiration for several speakers. And after that, it will be time for action. And there is a specific role for you watching today's show. You can ask questions to the speakers. I'll explain to you a little bit more about that later on in this show, but you can also participate in group brainstorms. In the final part of today's program, we will go into carefully selected groups where you will have a quick and secure brainstorm on the first steps that we need to take in the search for innovation. That is today's program. But we're going to start with the why, the need for change. And that consists of several steps. We're going to watch a video, there'll be an interview, and we will have our first speaker. But first of all, I would like you to sit up straight if you're at home or at your office or wherever you are, to watch our first video where 4 patients will tell you more about why it is so important to look for innovation. Let's start with our video.
The impact of living with kidney failure is huge. Innovations on clinical level and the level of life quality are very much needed. In order to find the innovations that will serve the patients, their voice must be heard. Patients from the Netherlands, the UK and Denmark raised their voice to contribute to this webinar on innovation. This is the impact of kidney disease on their lives.
I think the biggest effect kidney disorder has had on my life is the fact that I was used to traveling quite a bit. I mean, I used to be on the road more than I was at my home. And that is impossible now. My name is Henning Sondergaard, and I work as a psychologist for the Danish Kidney Association.
My name's William. I live in the UK. I'm a dialysis patient, been on dialysis for 27 years, and it had an impact on me mentally at the age of 19. And a lot of other people on dialysis were older, so it was harder for me as a young person wanting to work and go to university and those things that most normal people do at that age. I struggled and wasn't really able to do the things that I would have normally have done.
My name is Fiona Loud. I am the Policy Director for the UK Kidney Patient Charity, which is called Kidney Care UK. I am also a kidney patient myself, and I've spent 5 years on kidney dialysis when my kidneys failed. I still see my friends, but if we were to go out for supper or drinks, I could not drink anything, I couldn't eat anything. I went away for a weekend once with a couple of times with them, and I had to spend at least 2 of the afternoons of 2 days away back in bed again because I just didn't have enough energy to go walking around.
My name is Wim Sipma, and I have a background in business economics and marketing. That was also my job before I got ill. And I was very tired, I had no energy, and I felt, very ill, and I didn't see any hope for the future.
The patients do not have the impression that there was enough progression over the past years when it comes to innovation.
I look at the mortality rates in the last 50 years, and I don't see any big improvements there, as far as I know.
They're basically still the same technology as they were 50 years ago, which is horrible. I mean, it blows my mind that that can happen. And usually what I say is if the innovation in consumer electronics had been like the innovations in dialysis machines, my laptop or my phone for that matter would be the size of 4 New York City blocks.
I think any innovation should try and balance clinical need and quality of life so that people don't have to compromise so much.
But they do have hope for the future, and they are willing to contribute.
I think the most important thing we can do in order to further innovation in renal replacement therapy is start working together.
I think everyone should try and be open-minded about other people's opinions and perhaps patients' opinions.
I think in the future we should also focus not on technological innovations, but also how to make dialysis more comfortable for people and make the time on dialysis more acceptable.
We need innovation in the kidney treatment area. So I'm going to start with the dialysis machines. Mostly they are very big, they are very noisy, they have lots of lights, they clonk. We need machines that are easier to use, that are quieter, and perhaps some of them, because they're quite old technology, need an awful lot of technician support as well to make them right.
Innovations improve the lives of patients, and that makes all our efforts meaningful.
My new kidney is saving my life in an important way, because my quality of life has risen, well, sky high, I would say, and I'm full of life.
10 years earlier, I'd given up my hobby, which was I'm a drummer. I used to play in a band. And I combined my camper van with playing in a band to go to France for 8 days a few years ago. And we played around northern France. Being able to do something I enjoy again that my disease stopped me from doing was quite a big change. A dream come true.
Well, a thank you to Wim Sipma, Henrik Sundergaard, William Withers and Fiona Loud for giving insights in, well, the burdens they have to carry and the innovation that they're really hoping for. And then just to imagine that there are only 4 of millions of people that have sort of the same stories and the same hopes and the same aspirations. And they really show us why we're here today, why we're having this discussion. And in the studio, I'm now joined by Tom Oosterman, Oostrom, who is the Managing Director of the Dutch Kidney Foundation. Welcome. Our only, well, not the only guest studio today, there's one more. And also I'm joined by Christoph Warner, President of the ERA-EDTA. Mr. Warner, just to check first if you can hear and see us. We can see you, but we're now hoping that we can hear you as well.
It's all perfect, thank you.
Good. Where are you situated? It looks like you're in an office. Whereabouts are you? What city and where is the office located?
The University Hospital in the town of Würzburg, northern Bavaria. And indeed, I'm in my office and I still have the tie on from the Congress, which just stopped an hour ago.
Good, and you're in the same time zone as we are, so that's good to both of us. My first question to you would be, if you look at this video, this really shows the urgency for innovation, doesn't it?
Absolutely. We had a number of innovation technology in the last years. I'm a clinician. I cared for dialysis patients for many, many years and now moved to pre-dialysis and prevention and keeping patients off of dialysis. Mm-hmm. So I see both sides in the moment.
Okay, you've just recently become the president of ERA-EDTA, taking over from Carmine Zoccali. How are your first days, weeks in the office? What is the first thing that has struck you as the new president, and what are your main goal for the coming years?
I'm very excited about this virtual format, which has a number of really advantages. On the other hand, I miss a little bit the networking and looking into the eyes of the colleagues. So hopefully next year in Berlin, we have a hybrid both. And I'm looking forward to this. So the first day, congratulations and excitement. And tomorrow the work starts.
Okay. Now here in the studio, like I said before, Tom Oostrom from the Dutch Kidney Foundation. What has really been the starting point of this initiative to work together with the Dutch Kidney Foundation, ERA-EDTA, and the European Kidney Alliance? Where did it all start?
Well, in fact, we already collaborate for many years within EKHA, that is the European Kidney Health Alliance. ERA-EDTA is a member of it, but also the nurses, ERA-EDTA, EKHA-EDTA, and also the EKPF, the patients' organization, and the Dutch Kidney Foundation. The reason we started this is because we want to ask attention for kidney health in Europe. So EKHA, and Professor Van Holder will tell us more about it, his work is asking attention for prevention, for early detection, also managing kidney disease. What you hear from the patients now in this short movie is that they are asking attention for innovation. And I think that's very important because if we look at the facts, CKD, chronic kidney disease, it was in 2016 the 16th cause of early death, and in 2030 or 40 it will be already the 5th cause of early death. Yeah. And on the other side, what we see is that if people are dependent on renal replacement therapy, it is only accessible for 1/3 of the people worldwide. Yeah. So there is a real reason to ask attention for innovation, for improvements for patients. Yeah, because that's really what the WHO was saying, that it's a growing concern worldwide. It is absolutely, because it is related with diabetes and cardiovascular disease and hypertension. So it is a real problem because we are getting older. There is also some unhealthy lifestyle playing a role in this. But what we want is finally is that patients have a better life. And that's also what you hear from these patients. It is not easy for them to have a working life, a social life. It has personal consequences. So we want to give them their life back. And I think that's very important of this lobby. We are starting now together, this collaboration. And I'm hopeful about it. And I'm also really happy that in this webinar, we also have Murray Sheldon from the Kidney Health Initiative. He's telling more about the initiatives there. Yeah. So there are some positive developments that may be, well, will have positive consequences for the patients in the future. Okay, there is hope. Absolutely. Good. Now you're also, well, the Dutch Kidney Foundation is also one of the drivers behind the Neo Kidney Project. Yeah. What is the Neo Kidney Project? The Neo Kidney project is a project of our partner, Biotech in Switzerland, and our partners in Dialysis in Singapore. Together we are making a small kidney that is portable. In the current situation, if you are dependent on dialysis, you have to adapt your life to the treatment. We want to change that. We want that the treatment adapts to the life of the patient, so you can lead your life as you want. Because for kidney patients, the most important word is autonomy, not to be dependent on treatment. So that's what we try to do, and we know there is a technology to realize this. So I'm really happy that we are the partner in this project, and we hope to make a change for these patients.
So is this also then going to be part of the whole strive towards innovation within Europe? Is that one of the sort of a showcase that we can use within Europe to drive innovation?
It is one of the showcases. I think we should do more. We should also invest in regenerative medicine, because that will be even better if you can treat the kidney patients before going in dialysis. So I think it's a kind of roadmap we are making now for the future. And as I said before, EKHA is also investing in prevention. I think prevention is finally the best to do. But we know not everybody can be prevented with a kidney disease. So it's a kind of roadmap for the future. And what we see now in the EU is that they have a lot of attention for cancer, for cardiovascular disease, for mental disorders, not for CKD, for chronic kidney disease, not for end-stage kidney disease. So there is work to do.
Okay, work to do. Now, those were the final words of Mr. Wanner a minute ago, saying, well, tomorrow my work starts as president. What are the key issues regarding innovation and setting chronic kidney disease on the European agenda? That are the steps that you're going to, or hoping to take over the next years as president?
We have a lot to do about education. And this is very important in Central and Eastern Europe. There's still a large need. The Netherlands is a forefront runner. This year, we have the top number of new nephrologists joining the ERA-EDTA, and they are coming from the Netherlands. So actually, we are taking over some of the Dutch Kidney Foundation, which played a role model for so many years, maybe the strongest one in Europe. So we follow education, research, and the next generation nephrologists need to be brought into nephrology. This is very important for us.
And what are you hoping the result will be of today's session? So if you were to name one thing that we can see as a driver for success for the coming years, what will you be hoping for today?
We have a very, very new treatment which retards the progression of kidney disease. After 20 years, where we were waiting for an anti-diabetic, which also can be used in non-diabetic kidney disease, which delays dialysis for years. And this is something so exciting. We heard in several sessions over this meeting, and we are really looking forward to this.
Okay, so you're hoping that that will be taken a step further, or as in today?
I think this is a new milestone,
okay,
and takes a huge step further. We also had a huge engagement from the industry companies, which in the moment try to save lives in the COVID pandemic. And they have developed their plans. They had shown all their plans in sessions. They are really dedicated to keep patients healthy during this pandemic, and it looks much better now. All large companies are really now dedicated to do this.
Yeah. So basically, Mr. Oostom, there's not a lack of ideas and there's not a lack of inspiration. There really is a lack, or maybe a need, to take things further and to take more steps.
Absolutely. And also, like Christoph Wanner is saying, it needs to be done by more players. So not only by nephrologists, nurses, patients, or foundations, but also companies, also policymakers. So we need each other to realize this dream for kidney patients.
Yeah.
Yeah.
Okay, well, thank you for this moment. Thank you, Mr. Warner, for joining us. I hope you'll be with us for the rest of the afternoon. Thank you, Mr. Oostrom, for joining us. I'll be seeing you again at the end of this program because you're here in the studio. And let us then move forward now. And let me explain you a little bit further how our program is going to work. The first step we're now going to take is that we're going to listen to several speeches. Now, every speech will be about 10 minutes long. And during every speech, the speaker will, at the end, come up with two recommendations, two concrete recommendations that he or she would like to give forward to us, and that could be a first step toward more innovation and being even more successful within Europe when we're looking for innovation. And combined, these 2 or 3 recommendations will form a list of 9. And at the end of today's sessions, you will be sitting in your brainstorm session. And the question will then be if you can rank these recommendations into a top 3, the top 3 points that you think should be the first steps that should be taken next. So that really is one of the elements where you will be involved in today's program. But also, like I said before, you can ask questions. In a minute, I will introduce our first speaker. And during the time that he's making his speech, delivering his speech, you can ask questions. Now, the way you do this, if you scroll downwards in the menu that you're in now, you can actually see a form where you can plot in your questions. Now, the questions will all be gathered here in our studio in Leeuwarden. And at the end of a speech, I will select, or 1 or 2 questions will be selected that I will bring forward to the speaker. Now, if your question is not being put forward, that doesn't mean that it will be lost, because we will tell the speaker that you came up with that question, and he can then choose to answer it to you personally or in another way. But we will select 1 or 2 questions. So please listen carefully when we start with our first speaker, and don't forget to ask your questions. Now, the first speaker that I would like to introduce to you is Raymond van Holder. And he is a nephrologist and published over 900 papers. He was the chairman of the European Uremic Toxin Work Group and the European Renal Best Practice. He is past president of the European Renal Association, European Dialysis and Transplant Association, and currently chairs the European Kidney Health Alliance and the European Chronic Disease Alliance. He will be delivering a speech on the impact of kidney disease on society and the need for change. So he is in our first block still of emphasizing how important the need for change is. And I can see him now when I look at my screen. I hope that Mr. van Holder can see me too and that you can hear me. Mr. van Holder, welcome.
Okay, yes, I had to switch my microphone on. Good afternoon. Hello, you hear me?
Yes, we can hear you perfectly, and we can also see you. Welcome, welcome in today's program. And also for you, the question, where are you located today?
I'm sitting on the Belgian coast in my confinement, so there is no problem. I'm in my office at the Belgian coast.
Well, for those of the people that are watching that have never been to the Belgian coast, I've been there many times, and it's a good place to be. So you're well situated. Now, you're our first speaker of today, and you are going to deliver a 10 to 15-minute speech, ending with 2 recommendations that you would like to put forward, to which people can then ask 1 or 2 questions. Now, normally when I introduce people in a program, you are being announced with a huge applause from the people in the audience. We can't hear the applause now, but I'm sure that worldwide people are now clapping the tables, clapping their hands and stamping their feet to give you a warm welcome as our first speaker. Ladies and gentlemen, Mr. Raymond van Holder. The floor is yours.
Okay. Thanks very much. I have to put on my slides and go back one. Are you seeing my slides?
Yes, we are.
Okay, then I go ahead. Good afternoon. Thank you very much for inviting me to give this lecture. which I gave the title, The Burden of CKD, the Unbearable Lightness of Disregard. And with disregard, I mean that the world that is surrounding us since many years is more or less disregarding this problem. But this is maybe also disregard from the nephrological community, which does not draw enough attention to the problem to those people in the outside world. Now I'm representing, but I have to move forward my slides and that doesn't work. Yeah, I'm representing European Kidney Health Alliance that has been explained already more or less by Tom and by yourself. It is a Brussels-based NGO that is defending the case of kidney patients and of the nephrological community at the level of the European Union, and from there, top to bottom, also at the national level. And we are representing not only the physicians, but also the nurses, the patients, and the foundations. And we have on board, amongst others, the major European societies of the nurses, the EDTA, the ERA-EDTA for the physicians, the Kidney Patient Federation, and finally the Dutch Kidney Foundation, which is obviously the most active European kidney foundation for the time being. And next to that, a number also of national nephrological societies. Now, if we would take 10 people and at the problem statistically, then at least 1 in 10 of these would have chronic kidney disease, which means that on the European level, 75 million Europeans suffer from chronic kidney disease, and worldwide the figure has been calculated to be 850 million. And of course, if we think kidney disease, we think mostly about the most severe degree that is necessitating renal replacement strategies to maintain quality of life and survival, as there is hemodialysis, but also an alternative form, peritoneal dialysis, kidney transplantation, which for the time being obviously offers the best quality of life. We should not forget that also for a number of patients, especially the frail elderly, conservative treatment is a valid option. But all in all, among all these, hemodialysis, which is the most expensive solution that does not necessarily offer the best quality of life, and especially in-center hemodialysis, is the one that is most frequently applied. Now, if we then compare the survival of dialysis patients, of renal replacement therapy patients, with the survival of another very severe and really confronting disease, which is cancer, then you can see that among different cancer types, kidney disease treatment, and especially hemodialysis, is actually ranking at a very high level of mortality and is preceded only by 2 specific types of cancer. If we then compare this to all cancer patients, in a global average, then actually kidney disease does worse. And if we look at peritoneal dialysis, it's not so much better. And even transplantation, although obviously this gives a better prognosis, still it's there somewhere in between the pack of other cancer diseases. And I took this comparison with cancer not by coincidence, because it is clear that the cancer group of patients and the oncologists all together, they were extremely successful over the last decades to promote cancer and to make advances in the treatment of cancer. And we should take this as an enlightening example of what we would like to do in future. Now, the thing is that renal replacement therapy is only at the end of the road, and that the problem, as a matter of fact, is starting much earlier. And among several studies, the slope of mortality is rising somewhere already from the moment a glomerular filtration rate of 75 milliliters per minute is reached, and according to some studies, even earlier at a glomerular filtration rate of 90 milliliters per minute. So that means at the moment that only 25% of kidney function is gone, whereas renal replacement therapy comes when about 90% of kidney function is gone. So this is a problem that affects much more people, about 100 times more people that are not treated with renal replacement therapy than those who are treated with renal replacement therapy. And as already mentioned, chronic kidney disease, which is now at number 16 of mortality causes, is predicted by 2040 to have risen to the number 5. And as you can see in this list, none of what is above is actually cancer anymore. So at that point, we will be on top of the list and above all other cancer causes. Now, we should not only look at the problem from a mortality side or a morbidity side, but there is also another way of looking at it, and also considering the loss of quality of life. And one of the ways to express this is by using DALYs. Those are disability adjusted life years. It means that, of course, if a person dies, 100% of life years are lost. But if disability occurs, also a certain percentage of life years are lost. And the more severe, the more severely quality of life is affected, the more closest it comes to 100%. And here we see a number of very remarkable evolutions over time. For instance, if we take communicable diseases, let's say infectious diseases, looking around the world, this is mostly malaria, tuberculosis, HIV, then actually there is a gain in DALYs, or I express it perhaps incorrectly, there is a decrease in the loss of life years lost, which means that the quality of life and or the survival in a certain sense is improving. But for the group of non-communicable diseases, to which also kidney disease is pertaining, then you see that the inverse direction is followed, and that there is actually a rise in loss of quality of life or a loss in survival. And then if you compare kidney disease with other chronic diseases, then it scores above average. So it is worse than the other chronic diseases, and especially CKD due to diabetes and due to hypertension, which are the main causes of chronic kidney disease, even have more loss of quality of life. So this is not a very good score. And one of the reasons why I took this example is because the evolution of DALYs and the presence of DALYs allows us also to compare the investment into research and into other initiatives regarding to those disorders. And here from time to time, I have to get away from the track of kidney disease, because one of the problems with kidney disease is that there are not so many direct data. So for some of these things, we will have to extrapolate. But in any way, if we take non-communicable, thus chronic diseases aggregated, and we look in the red bars to the proportion of global DALYs, and we compare this to an exemplary communicable disease, which is HIV. By the way, again, one area where a lot of lobbying has been done over the last few years, but the whole community of physicians, but also of patients, very intensively. Then we can see that for non-communicable diseases, the DALYs are huge, and in proportion, the investment in research is minimal. whereas for HIV, it's just the other way around. The DALYs are still of a certain importance, but obviously less than for chronic diseases, but the investment of community is extremely high. So that is something that has to change. And we can look at it also from another way, and that is, what does it cost to the community? If the community doesn't invest, then how does it invest in it? Is it by paying for treatment? And here I made a comparison between the healthcare cost of cancer on the left side, the light blue bar, and on the other side, the healthcare costs of CKD, which are aggregated, which means that we have, of course, several different aspects: dialysis in red, transplantation in green, and chronic kidney disease in purple. I must warn you from the beginning, I had to extrapolate data, so I had to bring together data from different studies. That's always a tricky business, but I can assure you that I tried to stay as much as possible on the conservative side. And on top of that, one of the reasons I had to do that is, again, because we don't have aggregated and reliable data on kidney disease in one single bulk approach. And then you can see that, as a matter of fact, the cost to society of kidney disease is not so much different from that of that horrible cancer disease. But we should not forget that there is not only chronic kidney disease, there is another form of kidney disease which is often forgotten, and which is acute kidney injury. And more we see people who are saying that the two of these diseases are actually communicating with each other, that they are complementary. And as a matter of fact, it is for sure that many of the patients with acute kidney injury end up in chronic kidney disease, and that many chronic kidney disease patients are developing acute kidney injury. And if we add those costs to the analysis, then the least we can say is that costs for kidney disease are at least similar to those of cancer. And even if some of these analyses would have been exaggerated, and for instance, if what we are calculating for acute kidney injury would be only 25% of what it is now in this analysis, then still we would be at the same level of cancer. So the question is then, if it costs that much, again, is there as much effort done to improve the fate of kidney patients, for instance, by performing research? And here I have to rely on American data, more exactly from the NIH. There is a comparison in what has been invested in research for cancer in blue, for Alzheimer in red, for cardiovascular disease in green, and for kidney disease in purple. And you can see that, again, kidney disease is coming out extremely low. And I must draw your attention to the fact that this is 2020. That was at a moment when the American government already decided to invest at least 10 times more in kidney disease than they did before. And actually, that is one of the initiatives that we take as an example. Now, your question, of course, will be, well, how is it done in Europe? What is the investment in kidney disease in Horizon 2020? Well, I found some data on cancer. It was 1.2 billion euro. So recalculated in dollars, that would be above what is mentioned here for the United States. But for kidney, I just simply did not find any data. And if you go on the website of the European Union and you look for their key health research areas, then quite simply you can go along the list. You find a number of things that are related to kidney disease, but the term kidney disease is not figuring in there at all. And as a matter of fact, if we go back to the list, most of these diseases somehow are related to acute kidney injury. Even also HIV, malaria, tuberculosis, they all have their link with kidney disease. So we think that there should be much more prevention and also much more investment in prevention. We take an example from what the Dutch Kidney Foundation has done. We think that most important in these analyses are prevention, personalized medicine, improving quality of life, and regenerative medicines projected somewhat further in future, I think, but one of the real new things that are going to change the field dramatically. And I just want to stress the importance of improving quality of life, something that is more dear to patients sometimes than their survival rate, and that has not drawn very much attention until very recently. And for instance, this example of itching, which has not very well been solved. Now, the last few months we saw appearing a number of randomized controlled trials that are finally finding a solution. But there is also this whole list of especially neurologic problems or mental problems, at least, that need to be solved better in future. This is a picture, a painting of Cassandra. Cassandra was a mythic figure who had the unhappy feature that she could exactly predict the future, but that nobody believed her. The reason was that she had refused to make love with Apollo, and that was really a very hard punishment. So we hope that we will not end up as the Cassandra of kidney disease in the years to come, and that on the contrary, we can take an example of the EU action on cancer over the last 30 years, which was extremely successful, and that this would be the thread along which we want to walk in the coming years. I thank you for your attention.
Thank you, Mr. Van Holler, for the first speech of today, a very inspiring speech. You told us about the numbers, first of all, 850 million people worldwide as CKD patients, a high mortality rate, a huge loss of quality of life, the costs compared to the cost of cancer, and a research funding there where there's a lack of research funding in the kidney disease area. Now, you have given us a list of two recommendations that you would like to put forward for the discussion later on. And the first one is that research in the EU should receive financial support, conform the burden of disease and societal costs. So basically you're saying there should be more financing from the EU for research for CKD patients. And the second recommendation is that the EU should support aggregated data collection on frequency, healthcare costs and costs due to loss of productivity. Now, the first point, I think you've elaborated a little bit on that. The second one, the support for aggregated data collection. Could you in one or two lines say a little bit more about that? Why do you think that is so important?
But I think, of course, you need data to design your politics in future and to know how to attack the problem. And we don't need only the data that we have for the time being, for instance, about mortality. That's quite reliable data, especially on patients on renal replacement therapy. But we need data on earlier stages. We need data on rare diseases. We need data on quality of life, and we need data on health economic issues and the balance between the investment in the treatment and the return to it. So, and if you compare this to what I showed in cancer, then when preparing this talk, maybe I missed some data, but I asked support from health economists, and as a matter of fact, they could not be of very much help, unless saying that that what I was doing was probably the best I could do. So on this part of the thing, there is certainly a responsibility for more activity. Okay. And if you allow me, I can give you also an example about what is bothering us extremely today, that's COVID-19. As a matter of fact, at least from my perception, I'm of course a retired nephrologist, so I'm no more active in clinic anymore. But from my perception and following the literature and what was coming in, the realization that kidney disease was also very severely affected came very late, relatively late, partly because the data came from China, probably, and the epidemiology was different, but also because somehow we knew it was diabetes and hypertension, so it was logical that kidney would follow, but it did not follow, and we knew that there was cytokine storm, but it also did not follow.
So basically that is to stress how important data is if you want to be successful. There's one question from our audience today. I don't know what part of the world it comes from, this question, but it sounds as follows. How can we aggregate all the multidisciplinary groups present in this consortium in one single coordinated effort to translate our ideas to a transplantable or clinically usable product?
Yes. Yeah, that's quite a complex question, of course.
And you only have 30 seconds to answer it.
I see many different parts of the problem. The first thing is, of course, that there are many medical specialties involved, and that they are somehow all interlinked, and that they should be brought together to make this kind of common effort. And I think for prevention, at least at the EU level, for the time being, we are advancing quite well. And for research as well, if you go to more advanced treatment, of course, I think it's more specifically kidney. And to my opinion, it's a bit like looking for a vaccine for COVID. There is no one company and there is no one group that is working on that. There are maybe 100. And at the end of the day, there will be several vaccines, but I think then you bring together the data and then you find finally the best solution. But I think aggregate is very good to go together to politicians to convince them. But for research, I would prefer to have this kind of not really competitive, but at least parallel initiatives, because otherwise, if you do streamline too much, I think there will be not necessarily something come out.
Okay, so basically there is a research part to the answer and there's a political part to the answer. We'll have to leave it at that. There were more questions put in, but my job is to look at the clock and to make sure that we run on time. So we'll have to leave it at this. We'll put forward the other questions that were being asked to you, so maybe you can answer those one-on-one to the people that asked them.
But they can send me an email if they want.
Good. Well, thank you very much for being with us, and I hope you'll stay with us for the rest of the afternoon instead of going to the beautiful Belgian beach. But thank you for being with us and being our first speaker today, Mr. Raymond van Holle. Thank you. Before we move to our next speaker, one of the other questions that have been put forward is, will there be a recording or summary available of this webinar? Well, the answer to that question is yes. Tomorrow you will receive links to recordings, and also you will receive a summary of today's meeting. So that's the answer to that question. Now, I told you earlier that we have 3 parts of our program. The first part ends here, the need for change. I think it's been emphasized via different speakers, a video, an interview and a speech of Mr. Van Holle. And we will now move to the second part, which is the inspirational part, where we have 3 angles, 3 people, 3 speakers that will give us from a different perspective insight into ideas that could help us to bring about the hard-needed innovation. And the first speaker will be Murray Sheldon, and you can here see his CV on the slide. Murray Sheldon is an Associate Director for Technology and Innovation at the FDA, the Food and Drug Administration in the US. For many years, he has worked for medical device industry, leading device development projects and providing expert consultative services to numerous startup innovative medical device development firms. And currently, Mr. Murray leads the Medical Device Payer Communication Task Force, identifying methods to streamline the pattern from FDA approval to reimbursement. And he's with us today. Mr. Sheldon, let's see if, yes, I can see you. Let me first of all check whether you can see us and whether you can hear us. Mr. Sheldon.
Yes, I can hear you. I'm just setting a link to my talk in just a moment. I do have an echo, however.
Okay, well, we'll see if technicians can help to avoid this echo. Can I just start with asking you also, which part of the world are you at the moment and what's the time zone you're in?
At the moment, I am in California where I live. It's Pacific Standard Daylight Savings Time, 6:20 in the morning. And thank you for the echo, it's fixed.
Morning to you. I hope you've had your first coffee, so that you are right in trouble. You look right and sharp to deliver your speech. Have you got your PowerPoint sorted out? So are you ready to start your presentation?
I think so. Can you see my screen?
No, we can't see the PowerPoint yet. Let's check if we can have a look at that. Let me, whilst people are trying to make this happen.
Yes, I did.
Tell the audience that in your speech you'll tell us more about the Kidney Health Initiative, which is an initiative in the US that has been very successful, and that could be an example to how we could go about this within Europe. So that basically is the starting point from Mr. Sheldon's speech. Also, again, I remind you of the fact that you can ask questions via the way I told you earlier. If you scroll down, you can fill in the form, and we'll see if we can select one or two of those questions. And also, Mr. Sheldon will end with 2 recommendations that you will then discuss later on in our program. Now, I hope the technical challenges of getting the PowerPoint presentation on have been solved. I can't see it yet, but if anyone could give some information on how far we are on getting this done, then we know whether we can start with Mr. Sheldon's speech.
Wimmer, did you get my connection, my link? I've sent it twice.
Now, there might be a traffic jam on the digital highway between California and Leeuwarden here in the Netherlands, which is a long way, but it should work somehow. And I can see that there is some communication going between Mr. Sheldon and our technicians here in the Netherlands to see if we can get the PowerPoint going.
We can start.
We can start, okay. So then the next 10 minutes are for Mr. Murray Sheldon to tell us a little bit more about the Kidney Health Initiative. Mr. Sheldon, the floor is yours.
Thank you very much. I really am honored to be here at this meeting. If you wouldn't mind, I'm getting a bad echo again. It's getting hard for me to listen. Great, much better. My name is Murray Sheldon. I'm a retired cardiac surgeon. Also spent about 10 years developing medical devices, mostly for cardiac diseases and issues, and about 8 years ago joined the Food and Drug Administration in the Center for Devices and Radiologic Health to be the Associate Director for Technology and Innovation. And I'd like to talk to you today a little bit about developments of a roadmap towards innovative renal replacement therapy and to amplify on a lot that's been said in the past. Well, of course, we're all very familiar with the problem. The most important thing is that dialysis has changed very little over the last 60 years, and we can definitely see the difference between this and other fields of innovation. clinical outcomes are poor, quality of life is poor, and the cost is enormous. And if we remember the words of Willem Kolff, who in Holland developed the first hemodialysis, it's always important to keep his words in mind, that if we're going to keep patients alive by artificial means, we incur the responsibility to see that it's a good life and an enjoyable life. Well, of course, the gold standard is a kidney transplant, and that is the best thing that we have. However, we're unable to meet the needs of all the patients with kidney transplants, somewhere between 20, 25, up to perhaps 40 to 45% of patients with end-stage renal disease can have a kidney transplant, depending on your country. But the current standard is what you're seeing on the right side of your screen, which is dialysis. And if you look at the changes in 60 years, well, of course, the machines are a little bit nicer. They're more bells and whistles, but it's essentially the same technology that we've had without much improvement. And if you talk to patients who are on dialysis and you ask them, what would you like to see developed? There's a lot of opportunities that you can see from the bottom, improving dialysis technologies, improved transplantation, drugs, etc. But at the top, 72% are interested in a next generation renal replacement therapy, such as a wearable or an artificial implantable kidney. And we believe that it's very important to listen to what the patients would like. So we're focusing here on treatments for end-stage renal disease. And if you ask the question why, well, of course, we've already discussed some of the answers: quality of life, low life expectancy. We've already seen this slide where hemodialysis has a mortality greater than nearly all cancers. But there's also an extremely high cost, at least in the United States. CMS, the Centers for Medicare and Medicaid Services, is the sole payer for end-stage renal disease dialysis, and the cost is going through the roof, up at about $34 billion. Some people think it's a little bit higher already, but the trajectory is up and it's projected to go up. But if you get to the real reason why, it's the people that are affected. The man sitting on the in the Grand Canyon going down the Colorado River is Bill Peckham. He is probably the best example of somebody who could dialyze anywhere in the world, and you see him on dialysis right now on his raft going down the Colorado River. He could dialyze and take care of himself all the time. Unfortunately, he had passed away last year, and that's the end result, and that's not good. And further on the right is my good friend Caleb, who I met several years ago. He's a 16-year-old boy who's had end-stage renal disease for a long time. He's been fortunate enough to have 2 kidney transplants. However, they both rejected, and he has full of antibodies and cannot have another transplant. So his life is he's kept alive by dialysis. And unfortunately, he's losing dialysis access in both of his arms. When I last met him about a year ago, he was going in to start dialysis access through his legs. Well, we know that eventually what's going to happen to Caleb. And so that's the reason why we really need to have innovation in this space. And you look at 50 years of changes in computing technology, and it's just enormous. It blows our mind what we're able to do. But why not for kidney patients? And even for other organs, we can see different types of artificial prostheses. And in the center, you have the picture of Willem Kolff with his machine. And this is the new artificial kidney. We think we can do better than that. And it's really, we need to ask ourselves the question, is this all pie in the sky? Can we really do this? Do we have the science to do it? Are we trying to do too much too fast? And I respond by saying, for people like Caleb, we can't do this fast enough. So what has been done so far? What do we have to lean on? Well, we've developed a portable peritoneal dialysis. This is a nice advancement to get people out and about, and portable home hemodialysis with the Neo Kidney project in Holland. We've also developed wearable artificial kidneys that are not fully on the market yet, but very, very close. And we've done a lot of good research on implantable bioengineered kidneys that include cells. Another approach that we're aware of is to take a kidney and decellularize it and recellularize it with human stem cells and renal cells to develop a kidney that we can then transplant into people. And if you look at vascularized kidney organoids, you can see that these look a lot like glomeruli. And so there's a lot of progress that is being made, and we need to put all of this progress together. So how do we get this done? We need to stop talking about it and do something about it. But I'd like to tell you that in my experience, this is very unlikely to follow the pattern of most medical products development, where you develop a company, you get some venture capital money, and you develop a product, and then you try to sell it. This is much more complicated. This success will require human kidney cells and biologics that may have to be developed in one part of the world and shipped across the world. And the technology expertise is just enormous, and the risks are very high. But not only that, it's not a problem for one country alone. It's a problem around the world. So in July 2019, President Trump issued an executive order, and in Section 6, you can see to encourage the development of an artificial kidney. And we can read through the entire executive order, but this is where we'd like to place a focus on the development of an implantable artificial kidney at some point. And it's essentially a Manhattan Project. This is a picture of Leslie Groves, who ran the Manhattan Project. And when you read what he writes in his book, Now It Can Be Told, you learn a lot that can be very helpful for us. And I've just highlighted some aspects of what he has said, that it really requires many individuals from many countries operating in many different fields over many years. So this is a pretty big problem, and it requires a large effort. And I believe we need to develop a Manhattan-type project for the development of an artificial kidney. So that's my vision, is the development of this kidney, and to develop an international consortium to develop the communication among people with the knowledge to develop an implantable artificial kidney that could be provided to people around the world free as a humanitarian effort for peace. And I think that it is possible. I need to put a disclaimer. This is not the policy of the FDA or my center or anybody else. This is my vision, and it's just mine and mine alone, and I'm willing to stand behind it. And to do this, various nations can contribute both their scientific and bioengineering expertise, as well as provide financial support for people with end-stage renal disease who can't have a transplant. And I vision this device to be manufactured in centers around the world, which will provide great economic benefit for all the countries in the world and distributed internationally to everybody who needs it. This will really yield a huge societal return on investment when we no longer have to use dialysis as our standard treatment for patients with end-stage renal disease. Well, we're already partway down the road. What do we have? The Kidney Health Initiative has developed a roadmap. We've put out the first edition in October of 2018. It's a living document, and it really describes how to get from here to there. We're hoping to get the next version out, updated by the end of this year. We've been sidelined a little bit with the COVID-19 issues. But we've also developed a program called Kidney X, which we're developing funding through a series of prize competitions. And what's critical is that patient participation is essential, and we have this built into Kidney X on a routine basis, including a patient innovator prize to learn from the patients about how we can improve what we're trying to do. This slide has already been shown that by 2040, chronic kidney disease is poised to reach number 5. But the problem, as we've seen in the global burden of disease in 2017, is by 2030, which isn't that far away, 14.5 million people around the world will have end-stage kidney disease, but only about a third will be able to be treated due to economic, social, and political factors. And more than 2 million people will die each year with little or no access to even hemodialysis or kidney transplant. And we have examples on how we can develop consortia for the good of humanity. The International Space Station, with 16 countries getting together, multiple organizations and launch sites in multiple places around the world. I think that's a good model to follow. But in the end, I'd like to leave you with this notion that if you want to, this is an old African proverb, if you want to go fast, you can go alone, but if you really want to go far, go together. And we want to go far. We want to have disruptive innovation to really change what we're doing. We don't want to just build a better dialysis machine. We need to go together worldwide to make this happen. I've been asked to give out 2 recommendations, and I put them on this slide. The first is to expand the integration of diverse expertise. To me, innovation flourishes at a triple intersection of knowledge, which is essential, opportunities, and anticipation of what are the most crucial components. But when you put these together, the magic of innovation occurs. And I just like the quote from George Bernard Shaw: if you have an apple and I have an apple and we exchange them, then you and I will each have an apple. But if you have an idea and I have an idea and we exchange these together, each of us will have 2 ideas. And that's the basis of developing diverse expertise and bringing people together. And the second major recommendation is to constantly fight for funding, to engage patients in their organizations, such as the National Kidney Foundation, the American Association of Kidney Patients. Seek philanthropy, get help, get money wherever we can. We're spending the money already, but we're spending it not in the best place. And I want to take this opportunity to thank you very, very much for the opportunity to present this information to you, and I'll be willing to take questions. Thank you.
Thank you, Mr. Sheldon, for your speech, telling us, well, starting off with telling us that there hasn't been much innovation on dialysis over the last, let's say, 30, 40 years. You've also given us insight in the huge concrete want of patients, what they are looking for, renal replacement therapy, that they want innovation there and what they're hoping for. You've also given us some ideas of what's already happening in the world of innovation. And then you told us about your personal vision that I'm sure a lot of people will share, that you're looking for an international consortium, people working together internationally, and that patient participation should be the central focus of this. And you've given us the 2 concrete recommendations. I'm now looking at my screen. If there is a question, yes, I do have a question. And the question that has come in is, what is the main reason, do you think, that there has been no innovation in the last 50 years? So what's the main reason where, well, there's been so much innovation on the cancer part, but not on research on this area? What's the reason for that?
So I'm not sure that I have a real answer. A lot of people have speculated, but from my opinion is that when we consider end-stage renal disease, people without kidney function will die. And fortunately, due to Willem Kolff, we have a treatment dialysis where people don't die. And we hit that spot and we've stayed there and we've become complacent and we don't get a sense of urgency. As a matter of fact, it was a few years ago when we actually started looking at mortality rates and comparing them to cancer. And most people who saw that data didn't believe it. Said, it's really that bad? Yes, it is. And worse, we haven't been focused on the quality of life of patients, which is absolutely horrible. I really can't say why we haven't had as much innovation as we need. Certainly, there's technological improvements that we will be developing through researchers, and we have a lot already. But I think probably in the end, it's the opportunity to bring the people together with different ideas in the fields of bioengineering, cell development, mechanical development, membranes, and so on. We really need to bring all the people together to make this happen.
Well, thank you very much for that. Thank you for your speech and for giving us the 2 recommendations. I can see 1 or 2 more questions coming in, but I'm afraid we'll have to leave it at that when I look at the clock. Thank you very much for being with us so early in the morning for you. On behalf of all the people watching, I wish you a very good long day there in California, and I hope that you'll stick with us a little bit more to hear more about our program. Mr. Murray Sheldon and people are now clapping worldwide in their office at their homes for your contribution. So thank you very much. Which brings
You're very welcome.
Okay, which brings us to our next speaker. And our next speaker is Anna Prokopkova, and she will deliver a speech on the successful cancer lobby. We've already heard quite a lot from both of our speakers on how successful cancer research and the cancer lobby has been, and I'm sure that we can learn a lot from that we can use in our advantage in our seek for innovation. Now here you can see the resume of Mrs. Prokopkova. She is ECLs, and ECL stands for the European Cancer Leagues. She is the advocacy and project manager responsible for coordinating ECL's overall policy input into decision-making processes on the EU level. Currently, she is actively involved in shaping Europe's Beating Cancer Plan, and she also coordinates the ECL Patient Support Working Group and acts as a liaison for the MEPs, towards the MEPs, against cancer interest group at the European Parliament. So she is from the cancer lobby, is heavily involved also in the European politics, and I'm sure that she can tell us a lot about where the success comes from. Let me first of all check, Mr. Prokopkova, if you can hear and see us. I can see you, but can you see and hear us?
Yes, I can hear you.
Now, we've already been in Germany, we've been in Belgium, we've been in California. Where are you located?
So ECL is located in Brussels, but a couple of weeks ago, I have actually moved to Prague to visit my family once the COVID restrictions started to lose a little bit. So currently in Prague. Okay, so we're now in Prague, which is also a beautiful city. But we're happy to hear from you to tell us a little bit more about the success of the cancer lobby. And again, I'm asking the people that if you want to put forward a question, please do so. But now the floor is to you. Thank you so much. I hope you can hear my slides, or you can see my slides. Okay, great. So good afternoon to those who are in Europe and or whatever timeline you're in. Good day. Well, so I was asked to show a bit about what can be sort of translated from the success of the cancer lobby to the kidney community. So first of all, I'm not sure if everyone is well familiar with what is going on at the EU level, so I will give a short introduction in what is currently happening and what is going on with the Europe's Beating Cancer Plan, and then I will backtrack a little bit and look into lobbying in general, and from also what I've heard from the previous presentations, what can we learn and how can we take this forward. So just to say a few words about ECL, we are a European umbrella of national and regional cancer societies. So these are the organizations that really deal with cancer throughout the entire patient pathway, from primary prevention up to the palliative care services. But of course, there is a lot more cancer organizations for connecting healthcare professionals and patients. And it's really, in Brussels, there is a very strong presence of different cancer stakeholders. I hope I can move the slides. Great. So to start with the EU cancer plan and how did we actually get there? So as I said, and as was said before, the cancer was basically strongly present at the EU level for not only the past decade, but also before. We had a joint action on cancer. This is now the third one going on. We had a cancer plan already in the 90s, so it's really not anything new. It just got revived again in this legislature and even in a larger sort of effort, let's say. So just focusing on this mandate, what happened? So ahead of the European elections, we already had the parties who presented their manifestos, and the Christian Democrat Party put cancer as one of their core things on their platform. They were in the previous mandate the largest political party at the European Parliament, and of course they wanted to duplicate this. So they were also looking for things that would be closer to the European citizens, and they picked cancer. First, they put together a 12-point manifesto, and then later, once Manfred Weber, who was a candidate for the president of the European Commission from that party, he also had his own personal manifesto of putting cancer on the top of the EU agenda. Well, why cancer, you may ask, because as you said, for instance, compared to the kidney community, cancer is way more visible. And I would say that at the moment, it's also, of course, COVID-19 and mental health and perhaps rare diseases in general. But so why was it cancer that was picked as the number one issue? So first of all, as I said, Manfred Weber was the Spitzenkandidat of the EPP party, heavily involved in this from the beginning. He himself had a brother who passed away from cancer. So this was something that was very, very close to his heart. And of course, as a smart politician, he knew that he is not alone in this. There is millions of people throughout Europe who have the same issue, who have also the same family history of cancer, or they have a friend who has cancer. And so they knew that this is also a topic that a lot of Europeans can relate to, unlike other European policy topics that are perhaps more complex, such as the data space for diseases and so on, which are a bit more difficult to explain. So it was the perfect topic. And also at the same time, they were looking toward the future. And if you count cancer as the group of diseases, not looking individually at lung cancer or breast cancer and so on, if you're looking at them all together, it will be number one cause of cancer in Europe very soon. And for some countries, this is already the case. At the same time, 40% of cancers are currently preventable if we follow prevention either from the European Code Against Cancer, which is the primary sort of lifestyle changes, or by other more structural and governmental interventions. And of course, big sort of thing is that, as you said before, there needs to be a lot of stakeholders behind these ideas, and it's not enough to just have patients and civil society supporting the cause, but you also need industry, because they are a very, very powerful player in shaping decision making and putting things on the agenda. And from basically in the early 2000s and in the agenda up to 2023, about 40% of all of global R&D of the medical industry is now in cancer. So they also had a lot of stake to focus on cancer themselves. Well, what happened in the past in the past couple of months, basically we had the European elections. The Christian Democrats won, so they stuck to their guts and they said that cancer will be on the top of the European agenda, even though it wasn't Manfred Weber who brought it, but Ursula von der Leyen, who also happens to have a family history of cancer. So she stuck to it. She appointed two commissioners, Stella Kyriakides for health and Maria Gabriel for research, that are in charge of these two important cancer files. First is the Europe's Beating Cancer Plan, which is a commission communication. It would be about 30 pages of suggesting different interventions in cancer, really from prevention up to treatment, how to support member states, where to invest, where to change legislation, where to maybe put more things on the European level, where does it make sense to keep it at the local level, and so on. And then also, of course, we have the next research framework, which will be Horizon Europe, so substituting Horizon 2020. And one of the 5 missions is on cancer. So there will be a very, very strong research focus as well that is currently being defined. As we heard, COVID-19 is not really affecting the Beating Cancer Plan, and the final communication still should be published at the end of this year. In regard of the European Parliament, I know that there is different groups. For instance, there is also a kidney group at the European Parliament, and there is a cancer group which exists actually since 2005 there, so it's quite long-standing. And as it was said, we have the secretariat of this group, and I coordinate it. And well, we had amazing engagement this year, and it's thanks to the basically cancer being high on the agenda, and we have 128 MEPs actually engaged in this group, while the official channels of feeding to the cancer plan from the European Parliament has not yet been established because of the remote working throughout the corona crisis. So this is yet to be seen how they will tackle this. I would say that the key components that really put the cancer plan on the top of the agenda of this mandate were these 3. It was the powerful protagonist, which was Manfred Weber, and he persuaded the EPP party that this is the way to go for the elections. At the same time, elections are great for being able to bring on change in the agenda. So, because, for instance, if we look at the previous commission, which was under Jean-Claude Juncker, there was basically the entire mandate, not a single health file on the agenda. And at the end, there was health technology assessment, which is still being discussed. But now there is a really increased, whether this is now even more after the COVID pandemic, but also before with the cancer plan, there is increased efforts in this field, and the health directorate of the Commission was also strengthened. So the European elections, they brought the opportunity for change. And of course, as I said, it's not only ECL who is very, very active, but it's the entire cancer community, including the industry, who is behind driving all of these policies. So these 3 components just needed to happen in order for the cancer plan to happen. But I would just like to focus a little bit on generally, if there is no cancer kidney plan, for instance, so how can you still run a successful lobby for the years to come? So there is 6 points that I would like to highlight that are absolutely necessary to have a robust policy strategy or lobby strategy. First is to know what you're fighting for and pick your battle. And from listening to the other presenters, this is something that EKHA already has quite well defined. You know your story and you know the main issues. Do your homework. This is an important one, because you always need to know what your key points are and do a tremendous amount of research to basically know who the other players are. And also, together with doing the stakeholder mapping, you have to know who are your foes, who are your friends, and who can you align with, who you should maybe spend more time convincing, whether this is industry or decision makers, funders, and so on. Then, of course, the media engagement, and this was, I, for instance, saw that in the United States, this topic was, for instance, brought on last week tonight by John Oliver. In Europe, at the EU level, Politico has quite strong voice. So this is something that if you want to run a successful campaign, the support of the media, whether it's traditional or social, is absolutely necessary. Then one of the main things as well is speaking the policy makers' language. It's not only knowing the facts and figures, which is very, very important, but also to translate them into concrete messages. For this, you need to know the mandate. You need to know on which level you should advocate. For instance, there's a lot of problems in healthcare that people really don't know, and they are asking EU to do things, and maybe it's too vague, and maybe it's nothing out of their mandate. So really knowing which tools are available and how they should be used is very important to be able to have a strong, robust advocacy strategy. And last but not least, of course, to stay vigilant on the ongoing initiatives and to see how can you, even though there is no kidney specific file, how can you put the kidney issue into different files. So concretely now, from the current, I would say that there is two levels from how you can currently engage. First, as I said, is the strategy. So getting your goals and really trying to cross board on couple of objectives and trying to really tackle not only from the policy perspective, such as having meetings and putting position papers and reaching out to decision makers, but also there's other tools that you can use, such as campaigning or legal aspects, trying to strive for legislation changes. So it's really important to act within the entire area. At the same time, knowing, as I said, the regulatory framework and the actors within and who's responsible for what is absolutely really, really, really important. Once you know all that, you can move to the other sort of aspect, which is the visibility and the network, and knowing the concrete sort of policies where you can act. And if you're doing a bit of monitoring what is going on, so now is the cancer plan, but they also, DG Sante, which is the health directorate, they already said that this is for cancer, but it should be very inclusive toward chronic diseases. So if you have any issues that might be relevant for both patient groups, this should be reflected, whether this is access to expensive treatments or not enough innovation. It's worth to participate in the cancer debate as well, because it can also spill over to other disease areas, which is something that the Commission has said multiple times. There will be a new pharmaceutical strategy. There is there was the new medical device regulation. So currently, I also one of the main things is that actually this was announced on the 27th of May that we will have between 2021 and 2027 amazingly increased health budget of 9.4 billion euros, where currently, if I looked at the annex of different actions and I key searched cancer, it was mentioned 13 times, and when I key searched kidney, it wasn't mentioned at all. So maybe this is somewhere where you can see who are the reporters for this file, see how you can add kidney into this health budget. So it's called EU for Health initiatives, which will really shape the EU health investments for the 7-year period as of 2021. And then, of course, building strong networks. So as I said, beyond patients and healthcare professionals, you also really do need industry, because they are if innovation and lack of innovation is the problem, you absolutely do need to establish relationship and work well with them. So I put down these 3 takeaways. So first, to set the goals and political asks, and I think that you have that covered. So I would focus as my 2 main recommendations on the other 2, which would be the building of the strong network and partnership and taking part of the initiatives. So this could be really be reactive toward what is happening at the EU level, and at the same time be also proactive, trying to put your own statements that are just connected to the kidney health, but also make sure that you really are participating. And of course, if you are participating, you really do need to speak the decision maker's language. So this is something really that if it's amendments or if it's recommendations, because if you put it in their language, the decision makers, they are very likely to copy paste your text and put it in the official documents. So the way you phrase it is absolutely important. And I thank you also for this opportunity to present, and here are my contact details. You can reach out to us as well at ECL in case you have any questions, or I'm happy to take any questions right now. Thank you.
Well, thank you very much, Ms. Prokopkova, for your speech. I'm lost in your name because I've been writing so much, because this really was a brilliant masterclass in how you put forward a good lobby within the European Union. So I'm sure a lot of people like myself have been writing everything down that you've been saying. I won't summarize it because you've really given very clearly what your takeaways are. And the things that really struck to me are the ones that you have to make things personal. That's where you started with. You need a strong protagonist. You need the right moment. You need to speak the right language. You need to build your network. Basically, there's a lot of work that needs to be done. How big has the team been that you've been working with? Because you haven't done this all on your own, I suppose.
Well, our team actually at ECL is quite small. So we are a team of 4 people, but of course we are not doing this on our own. We are a coalition of 29 cancer societies in 25 European countries, and we are really blessed with some very, very active, brilliant members that are helping us develop all these advocacy strategies, and that this is something that is very crucial as well in healthcare. If you're doing things at the EU level, being able to connect to the capitals. So without it, it's absolutely not possible. So to make sure that you have aligned your advocacy in the capitals, but as well at the EU level, and knowing who to ask what. And of course, our members, they're fantastic, and they're helping us with this.
Final question, how important is it to be based in Brussels? That's where you're normally based. Do you feel it's very eminent to be right there on the spot where the decisions are being made?
Well, I would say for the past 3 months, a bit less, and we will see how this will evolve in the coming months. But from experience, it is quite important. We have a couple of members that actually even come to Brussels quite often. These are whether they are located in London or Amsterdam, when it's easy to get there. But it's absolutely necessary because there is so many different meetings. And for instance, when we are running the MEPs group of 128 MEPs and we need to meet with them often, then there is a lot of networking opportunities. So I would say it's quite important to have a robust European strategy.
Okay. Well, thank you very much for being with us today. Good luck with your lobby work from Prague or when you're back in Brussels. In Brussels, it was great to have you with us. And I'm sure that people have learned a lot and they will take your advice and they will use it for a successful lobby for the chronic kidney disease. So thank you very much, Mrs. Anna Prokopkova from Prague. Thank you. Thank you. Now, ladies and gentlemen, we've had 2 perspectives. We've heard from the Kidney Health Initiative from California, from Mr. Sheldon. We've heard from Ms. Prokopkova from the Successful Cancer Lobby. And we'll now go from the 3rd perspective. And the 3rd perspective will be given by Clemens van Blitterswijk, who will join me here in our studio. He is our 2nd studio guest today. And I will interview him, and he will also show us 1 or 2 videos. And let me tell you a little bit more about Mr. Clemens van Blitterswijk. For those of you who don't know, well, it's already here on the list. He is Institute Director at the MERLN Institute for Technology-Inspired Regenerative Medicine at Maastricht University here in the Netherlands. And he's internationally known for his pioneering work in tissue engineering. which aims to replace or regenerate diseased or damaged tissues through a combination of biology and engineering. And he's also the founding father of RegMed XB, and he is a member of the advisory board of Neo Kidney, of which we spoke earlier. And he's also a partner of the Life Science Partners, one of Europe's largest and most experienced healthcare investment firms. And that is not a complete summary of your resume, but just a short recap. Thank you for being with us here in Leeuwarden. I saw you looking very interesting watching the last speech with the advice from the cancer lobby. What's the most important thing that was new to you that you think we can use in today's program?
Well, but first a little remark. You mentioned our institute, and you spelled it as M-E-R-L-N. It actually is Merlin, and we work magic in regenerative medicine. So that explains the name. And actually, I've listened to all talks with great interest. And perhaps I found most inspirational the statement where it was said we should try to make something work, biological, and should make it available for everybody at no cost as a contribution to world peace. And certainly in these COVID-19 times, I found it very appealing. And actually it might also be very smart, because one of the issues in bringing improvement in the field of renal replacement is that we have an industrial model which works very well for the current players. And it might be very hard to disrupt it with new technology. And so perhaps you might want to make it free for everybody in order to make it work. But that was just one thought which I had while listening to the previous presentation.
So you dare say that could well be one of the reasons why innovation isn't going the way we would like in our field of work, because the system we have now works well for the people that have to work with it, apart from the patients.
Yeah, it might be one of the disadvantages that this field has moved ahead very fast quite a long time ago in the period of Willem Kolff. And because of that, it developed a very successful industry. It developed a working model. And if you want to come up with something new and something better, you need to disrupt that entire model. Yeah. And if you think about lobbying, when we think about the last presentation, and then you might even expect some counter-lobbying by the established field. Yeah. I don't know if that will be the major issue. It might be that industry active in this field thinks about it very, very differently, but it could be an important part of it. Yeah. Especially because technology-wise, and that's my field, I'm a bioengineer or tissue engineer, I'm absolutely convinced that the state of technology which we have today allows us to do a really good job if we would focus our efforts and would have the budget available.
So technology is not the problem here?
Well, we still need a couple of years to make it all work, but I would like to show you in a movie an individual who I find very inspirational. And if you look at that movie, how he was able to bring that innovation with very limited means, and you realize what we have available now, then I think we should be ashamed of ourselves that we haven't done a better job yet.
Yes, you're mentioning now that you've brought with you a video of a TED Talk you gave earlier in Maastricht. And let's watch that video first and then ask you some questions about it. But let's watch the first part of the video.
Now, before we go there, I would like to ask you, who recognizes this man? Please raise your hands if you do. Yeah, that's not a high number, it's 0. So you probably need a clue. And I'm going to give you not a single clue, I'm going to give you 3 clues. Here they are. A laundry machine, tin cans, soda cans, and a high-quality sausage. So I'm going to try again. Who knows this man? Yeah, that's disappointing. But frankly, it's not a surprise. Because when you and I look at these objects, all we see is just the laundry machine, the sausage, and the cans. But when Willem Kolff, because that is his name, would still be among us, he would look at those objects and he would see the components that helped him build the world's first kidney dialysis machine during the Second World War. The first patients died, as anyone would at that time with kidney failure, but then the first survived. And that was the first one of a long and continuing series. Here you see Fabian. Fabian is one of the patients that helps us on our venture. He is one of the 2 million on dialysis this year. That's not great. His life expectancy will go up with 5 years, but it is a bothersome life. Still, it is estimated that since Cole's invention, 750 million years have been added in man years. Well, that's impressive. It's staggering. And probably now you understand why this man is my hero. But you would be mistaken, because that makes him just a mere role model. What made him a hero is the following story. While he was working on his dialysis machine, the Germans started transports from Rotterdam to the war industry in Germany. 50,000 people were being transported, prisoners, Jews among them, people of the resistance, and they had a stopover in Kampen where Kolff had his hospital. And what he did, he was able to save 1,238 people, so that's this room, from those lethal, often, transports. How did he do it? Some of them were really ill, so they had to be taken to hospital. Others he would make administratively ill, and if it was really necessary, he would make them physically ill. And there was this Oberleutnant Braats who was in charge of the transports, and he suspected that something was going on. So he went to Kolff and he told him, look, Kolff, I think I know what you're doing, and if I'm able to prove it, then werden Sie erschossen, Dr. Kolff. And Kolff went on, saving lives. Now that I would call a hero. And this man, during that talk in The Hague, 20 or more years ago, gave the following message. Kolff said, if only we would spend a budget of 1 nuclear submarine, a boomer, on finding a cure for these people, create organ repair, they will no longer be depending on dialysis. Now, I find that an appealing idea.
Yes, the story of Willem Kolff.
Yeah.
Now, one of the 2 recommendations that you wanted to give to the audience, because in a minute they will go and in their small groups to have a group discussion and rank those recommendations. One of the recommendations you wanted to give was select a grand source of inspiration.
Yeah. Yeah, this is such a grand source of inspiration. Yeah. And it's surprising that about 30 years after I heard this presentation, or 20 years I heard this presentation from Kolff, we did not follow up on his advice. So here you have this great innovator, who is also a great character, so he must be right if he says something, and we have not been able to allocate that budget. Perhaps the example was the wrong one, a nuclear submarine. Perhaps some of us like that. Yeah. So perhaps Kolff should not be the example. Perhaps you saw in the picture a patient on dialysis. Yeah. It is Fabian. We work with Fabian every now and again with the Kidney Foundation. And Fabian has a hereditary disease which necessitates his treatment. Fabian also has a son, and his son has the same disease. And I think that's something which we should think about, that with all our knowledge and all the budget available, we still find as a society it is acceptable to let this son grow up and still be dependent on kidney dialysis with all the disadvantages of that technology. So perhaps it's those children that should be our source of inspiration.
Yeah. Yes, well, that sounds wonderful. As in that was one of the things that Mrs. Prokopkova was also saying. You need to find the person, or you make it personal, make it close to people, to make them feel what we're actually talking about. Because the 850 million people is a huge number. But at the same time, it doesn't really strike people. So you
no, it doesn't reflect. It's what you currently see with the racism debate. We have one individual who has been treated very badly. And Of course, there are many people being treated badly every day in the entire world, but this triggers a response. Yeah. And perhaps that's something which we should try to do for these kidney patients, because they deserve a much better fate than they have today.
Yeah, so it's make it personal and the right timing at the same time. Yeah. Now, there was a second part of your TED Talk that you wanted to show us. Let's watch that first and then reflect on it.
I want you to look at this slide once more. All this budget, all this talent, but only in 0.2% of the entire world population. Use your imagination. What would happen if everybody in the world would back up our plan? And that's why I'm here today. That's why I'm talking to you in this audience, and that's why I'm talking to the people watching this video. We need your help. We need your help to convince the entire world to set free the budget of one nuclear submarine in order to make Cole's dream come true. We owe it to the man, our hero. You owe it to yourself. And you most certainly owe it to your children. A boomer for organ repair. Thank you.
Yes, well, this links to your second recommendation. Let me just read it out to the people watching us. Go for an absolute inspiring joint goal while assuring that all participants also fulfill sub-goals that are important to them individually. Let's focus on that second part. Yeah. Why is that so important?
Well, perhaps I should explain what has happened here. Eh? So after the message of Kolf, about a couple of years ago, together with the Kidney Foundation, a couple of scientists sat together. We looked at our scientific results recently, and they are staggering, you know, if you see what we can do as compared to what Kolf could do. And we thought we should no longer be depending on the actions of others in order to generate this type of budget and reach this moonshot of making a biological equivalent to renal replacement. We should just start to do it. Yeah. And that's what we did. We reached out to policymakers, to ministries, to the health foundations, to the researchers, universities, and we got them together. And what we learned during that process is that it only works, the moonshot itself, the great goal is not enough. Because everybody also thinks about his own interest. Yeah. So the major challenge was that we would have this great goal, a biological replacement, but at the same time we would take care for employment, very important for the provinces. The competitive climate in the Netherlands and Flanders were important for the ministries. Top quality research, very important for the universities. And if you bring all that together, then it starts to fly. Yeah. So we are proud on having raised about this 250 million, which is for organ repair in general, so not only for kidney replacement. But in this presentation I also said that the population of Flanders and the Netherlands is only 2% of the world population. It's only 2% of the talent in the world. Yeah. So imagine what we could do if we could bring this together. Certainly at the European level, but preferably together with the United States or with Asian countries, then we should be able to achieve a goal like that. But it will be difficult because the interest in the United States wants to be the main industrial player in making this technology available, and Europe is the same story. So perhaps that idea of making it available for free is not such a bad one.
That could be the solution. So basically you're saying, of course you have your own great goal. That was the great goal of the Dutch Kidney Foundation and others. But you have to link it to the goals of other people as well in order to get them going. Because they might be inspired by your goal, but they have to be able to tell their stakeholders why they are participating. So it has to be linked to them.
Yeah, and in that sense, it might be interesting that this started in the Netherlands, this particular initiative, because even here today we are below sea level, and we all build our dikes, and we need to do it, otherwise we drown. And if you want to build a dike, it might go through the land of a particular farmer, who may be convinced about the idea of protecting the country against the waters, but might not be very enthusiastic about having the dike in his particular land. So this is for which you have to find a solution as well. And that's what I mean with finding all these sub-goals.
Yes. And then we have to link it to something international, because of course here we're very, we care a lot about our dikes because they have our personal
Fortunately, not the entire world is below sea level.
No.
But the entire world is experiencing kidney issues.
Yes. In fact, we are safe here in Leeuwarden, so that people know, because we're above sea level here. There's a question from our audience to you. With the budget needed for, let's say, 100 square meter 4-lane highway, we could already do a huge leap forward. One country would have such budget, but not all the needed brains within its own borders. Do you think international cooperation is needed?
Yes, absolutely. I think in the fields of tissue engineering, biomaterials, the Netherlands and Flanders are quite good actually. But like I said, it's only 2% of the smart people. So it's absolutely essential. And actually that's also how we do it. In this program, which is Dutch money, we have said for those areas where we lack expertise, we can spend Dutch and Flemish money on getting the expertise in from abroad. Yeah. But still, that's not enough. In order to tackle this issue, we need to do it worldwide.
Yeah. Well, thank you very much for the information given. And people, I think, well, by now know a lot about NeoKidney, but if they want to know more, they can always find you and ask more questions about this. Thank you for being with us. What we will now do is we will move across the world again to ask 3 people just 1 or 2 questions before we actually go to our brainstorm. And the first person that I would like to move to is Mr. Norbert Lamer, who is the former president of ERA-EDTA and of EKHA, and he is chairman of the medical advisory board of the NeoKidney project, Next Kidney. Now, the question I would like to ask to you has been said by several people here on the stage before, how important it is to get the patients involved. And I was told that you really also wanted to stress this point by giving maybe 1 or 2 examples why this is so important.
Do you hear me?
Yes, we can perfectly hear you. Okay.
So it's a pleasure to be with you. So the question is, if I understand well, why is it so important in for example, in clinical practice and in research in artificial organs or in general, in nephrology in general, why is it important to involve the patients?
Yes.
There is a difference in timing between what I see on the Skype and what I say.
Okay.
No match.
You can just continue telling your story, and it'll work out fine.
Okay, fine. So for a long time in research, and nephrology in particular, the emphasis was always looked at from the point of the researcher, of the scientific researcher and the nephrologist. And if we did some clinical trials, that was reflected in the endpoint of such a trial, which were all very scientific, also very, very important, looking at mortality and looking at quality of vascular access and so on. But we forgot that actually besides the very objective endpoints, the patients were sometimes or often even more concerned with their subjective feelings and feelings that we did not take enough into account. So that it was decided, and I think, and I recommend that these so-called subjective patient feelings should also be included as endpoints in clinical trials. Because, I mean, controlling, for example, a parameter like phosphate and talking that to the patient that he should pay more attention to his diet, but on the same time forgetting that the major problem of that patient is that he feels very fatigued, very much fatigued, that after each dialysis session, he has to go to bed because he cannot cope with it, that he misses the freedom to travel, that he is worried about the burden he puts by his disease on his family, these subjective, more subjective endpoints are equally important, to say not more important than the hard endpoints that are also important, but that we sometimes have forgotten in the past. And I think we can learn from what the patient is telling us. And many patients, because nephrologists do not feel what it means to be on a dialysis machine or on peritoneal dialysis, or even the burden even after they have been transplanted. So that's, I think, is crucial, that we should take this subjective patient-related outcomes in all our research and also in our daily clinical practice.
So basically you're saying that you have a medical way of looking at this, but we also have to get the personal way of looking at this involved as well. We have to really feel and hear and see what the patient is telling us, because maybe that's even more important to him or her than the medical aspect. He wants quality of life, and that doesn't maybe have to do with to cure it, but to improve his quality.
Absolutely. So there are ways to estimate or evaluate quality of life. These methods are, of course, not so quantitatively exact as you can look at a lab result where, you have a given number and the number is correct, we hope. But this is an aspect that the primary thing is you have to talk to your patient, not only for 2 minutes, but sometimes for a long time, and repeat the conversation. And then you will find out what actually is very important to such a patient, particularly a patient on hemodialysis.
Yes. Well, thank you very much.
I cannot enough emphasize this.
Yes, well, thank you very much for stressing that important point to us. I forgot to ask you where you are located at the moment, because that's what we want to hear.
I'm located at home. And so it is in a small village on the northern part of Ghent. As you know, I'm a retired professor of medicine. And due to the COVID-19 lockdown, I have to stay home. But I enjoy it.
But from my own experience, I know that Ghent is not the worst place to be located. It's another beautiful old city in Belgium. So thank you very much for being with us, Mr. Lemaire. And let us then move to our second guest that I would like to ask one or two questions, who is Jérôme Augustin, who is the CEO at Next Kidney. And we're now trying to make the connection to another place in Europe, in the world, or wherever Mr. Augustin is located at the moment. And I'm just trying to talk you through this whilst I'm trying to see whether we have Mr. Augustin with us. And maybe if that's not working, then we could first go to Mrs. Mary Lou Ratton, who is the Senior Medical Affairs Manager at Medtronic. But now I can see that we have Mr. Augustin. Welcome in today's program, Mr. Augustin. Can you hear and see us?
Hello, everybody. I could see you.
Good. Well, we can hear you and we can see a picture of you. Where are you located at the moment?
Alors.
Oh, I'm afraid we've lost.
I could see you, but I have an echo right now, and it's a little bit complicated. Yeah, sorry.
Okay, but let me then move.
I'm in Paris. I'm also, due to the COVID-19, I'm in Paris at home.
Okay, so you're in Paris. Now, my question to you would be, what your vision on innovation on RRT is, having heard what all the speakers before us have said. Now, this could...
Okay,
This could either mean that Mr. Augustin is thinking very hard for his answer, or it could mean that we have lost connection with Paris. And if that is the case, that we have lost connection to Paris, then maybe it is wise, also looking at the clock, to first move to Mrs. Mary Lou Ratton and see if we can make a connection with her. She's the Senior Medical Affairs Manager at Medtronic. I mentioned that before, an organization that's also heavily involved in innovation and working on finding innovation for chronic kidney disease. And she would also like to be with us to give us her views on the topics that we're talking about at the moment. Now, if we're waiting for her, let me then first explain to you what is going to happen next. What is going to happen next after I've asked those two questions is that we will then have the moment where we go into the different sub-sessions. Now, let me explain to you how this is going to work. Yesterday, you received a link to and a number of a group to which you belong. So that's the sub-session that you will be going to in a minute. So what you can do is look for that link, look for that email, and you can find the link underneath the screen that you can see now. So you need the number of the group that you are allotted to, and you can find the link to that group in your screen when you scroll downwards. Don't link on it yet, because we haven't started it yet, but that's where you can find where you're going to. You will then have a 20-minute session where you can discuss with the other people in your small group. And among the questions that we have been put forward to you. So we've been given 9 recommendations from our speakers. And in a minute, you will see them again on the screen here, the 9 recommendations. And the question to you is, with your group, please rank them to a top 3. So what are the 3 most important recommendations that you've received today? So in those 20 minutes, the question to you is to give us a number 1, 2, and 3 to do so. Now, every group will be chaired by a person, and that person knows that he or she is the chair. And maybe it is wise if that person already now goes to the group. So if he can already find the number and the link, go to the group so you can actually sit and wait for the participants to come towards you. This will take a couple of minutes. So if you're the chairperson, just sit and wait. And it might take 5 or 6 minutes, but then your group will join you. Now, that is what is going to happen. I don't really see the link to the people I was going to interview any further. So let me just check. So we are going to link to one of the 2 persons that I mentioned before. So the question is whether we now see Jérôme Augustin or Mary-Lou Retton, so that I can ask them the 1 or 2 questions that I was hoping to ask them earlier. So we have a Skype connection, and we're now hoping to actually make that connection to them. And whilst we're waiting, let me then explain to you that if you want to see again the list of the 9 recommendations, you can see on the schedule that you'll be shown in a minute, on the top of that, you can see a link to a website. And if you click on that website, you can then see the 9 recommendations again, so that during your discussions in your group, you can still look back at those connections and at those 9 recommendations. So that is what is going to happen in a second. We're still hoping to find connection with the 2 people I was going to interview.
Yes, I am.
Oh, you're already there. Okay, so we have a connection with Mary-Lou Retton. Mary-Lou, I don't think we can see you. I can't see you, but maybe the other people can see you. My question to you would be, as Senior Medical Affairs Manager at Medtronic, what do you see as the greatest challenge? You're really, as a company, into innovation. What do you see as the biggest challenge?
Well, I think... Hello?
Yes, we can hear you.
Okay. I think there are several big challenges for us as a company. We really would like to meet the needs of the patient. And we also recognize that dialysis is so complex. We know that we need to have a good vascular access. We need to have a green technology. We want to meet the needs of the patient. So I think our biggest challenge is to put these all together and to try and come out with really an effective treatment that's really meeting the needs of the patient, not just one aspect, or not just the technology aspect, but also what really can benefit the patient the most, also for their quality of life. And that's a little bit more difficult to have it in a tangible form as to what we need to develop.
Okay, so also you're saying we need to put the patient first and their needs. How do you as a company try to establish and really try to get to the heart of what the patient wants? Do you have a certain method you use for that you would like to advise to the other people that are watching us today?
Yes, right now we see that I also have an echo. We are trying very much to be in the field and to really understand, not just from the physicians, but also the patients themselves on what they think could be of benefit in the future developments.
Okay, well, thank you very much for answering those questions. I'm just now wondering whether we have Jérôme Augustin as well in our show, if we have connection with him via sound or view. Now, this is a long silence also for me, so I suppose that we don't have connection to Mr. Jérôme Augustin. Thank you very much to Mary Lou Rotten for joining us with sound and giving your view from Medtronic on this matter. And I think that we have now come to the moment that I hear hello. Is that Mr. Augustin? We have Mr. Augustin. Mr. Augustin.
Yes.
Welcome to our show. The question to you would be what your vision on innovation on RRT is as the CEO of Next Kidney.
Sorry, what did you... I have a terrible echo, I'm sorry, and I can't understand what you mean.
Okay, I'll repeat the question very slowly once more. What is your vision on innovation on RRT?
Yeah.
Okay, now I think still this is not working, which of course is very sad because we have Mr. Augustin probably doing his utmost best to be in contact with us, but somehow it's not working the way we'd like it to work. So the connection with Paris is not as good as we hoped. In that case, I think we should now move forward to our sessions. But before we move to our sessions, there is one more video that we would like to show you. So before you press on the link to the group that you want to go to, we first have a small video from a member of the European Parliament. Her name is Hilde Voetmans. She's chair of the MEP group of Kidney Health. She couldn't be with us live today, but she has recorded the message that I would like to show you right now.
Good afternoon, everybody. Unfortunately, I could not participate in this webinar, but I would like to leave a message on behalf of the MEP group for Kidney Health. We all know the problems very well. The waiting list for organ donation, also kidneys, are very long. Millions of people suffer from chronic kidney disease in Europe, and many of them depend on renal replacement therapy in order to continue their daily lives. While we made incredible progress in terms of innovation in many areas of healthcare and pharmaceutical sector, it seems that for those who suffer from kidney disease, the clock stood still for many years. There's a reason why they call chronic kidney disease the most neglected chronic disease. The European Union has invested successfully and rightfully in innovation in preventive and curative therapy for many diseases, such as cancer, for example. The results of those investments are there. They show that innovation is the key to success and to a better and healthier life for our citizens, and that Europe is capable of taking a pioneering role in research and development in the medical industry. But when it comes to chronic kidney disease, I believe, honestly, that more progress can and should be made. That's my message for you all today. This is not only your battle, it's our battle, a European battle. If we want to maintain our status of a pioneering continent, we cannot just stand by and watch the wave of new technology and innovation in other branches of the medical industry pass by. We have to fight for a better health of all Europeans, so also those thousands of patients who suffer from chronic kidney disease. More awareness in Europe, more European funding, more innovation. That is what I will be working for in the European Parliament over the next few years. Thank you very much.
Now, that was a message from the heart of the European Parliament, from a member of the European Parliament, the chair of the MEP Group for Kidney Health, saying that this is a European fight. So that they're very open for any ideas and suggestions and innovation. Now, this really is the moment that you will now go to your allocated group. So again, you can now click on the link with the number that suits you, that you've been allocated to. You will then find yourself in your subsession, and for the next 20 minutes, you can then have a discussion on which of the 9 recommendations you think should be listed in the top 3. And good luck with that discussion. I'll see you back in exactly 20 minutes. That is 1 minute to 5 o'clock. Good luck. Welcome back. I hope you all had a fruitful discussion with people from around the world trying to rank the 9 recommendations that were given to us by our speakers today, and that you actually managed to, well, discuss things with each other and maybe broadened your network, learned from each other, and got inspired by the ideas of other people. And that, of course, technically it all worked fine. We're all now back here at our plenary session, and what we're trying to do is just a wrap-up of what's happened, because we would like, of course, to now have a summary of all the groups, what they've done, which, of course, is impossible. So what we will do is, in a minute, I will show you the add-up of all the ranking results that have been brought in by the moderators per session, so that we can then see how every recommendation has been listed on that list. Maybe it's good to have a quick look at the list without having the numbers plotted to it, so that we can see what the 9 options were that you had to vote for. And at the same time, we will then try and connect to 3 moderators of 3 different sessions and hear from them just briefly what happened in their session and how they ranked the 3 topics. And then I will round up today's conference with a small interview with Tom Oostrom again of the Dutch Kidney Foundation. And then we can all either go to lunch, dinner, to bed, or have a drink, apart from the fact where you are at the moment at this time. Now let's look if we can make connection with the first moderator of one of the sessions.
Round up today's conference with a small interview with Tom Oostrom again of the Dutch Kidney Foundation, and then we can
become very happy of. Let's have a look and talk to the first moderator of a session, Marja Hodak, who is of the Dutch Nierpatiëntenvereniging Nederland, a patient society in the Netherlands. She moderated one of the sessions, and I'm now trying to see if I can see her. Well, yes, I can see Marja Hodak. Mrs. Hodak, can you hear and see me?
I can hear and see you very clearly. I hope you can see me as well, because I have to Skype by my phone, because my laptop is not supporting Skype at the moment. So it's a bit improvising, but I hope you can see me.
Good. Well, maybe if you can try and move the camera up just a little bit. Yes, that's wonderful. Then we can see a little bit more of your face. Now, you moderated one of the sessions. What was the main topic that you were discussing in your session?
The main topic that we were discussing was that we should probably merge a few of the recommendations, because none of them are non-feasible. And it was very obvious that the expansion of the integration of the diverse expertise, that was number 1 in our group. But we added some things to that, and we were inspired by Norbert Lemaire's speech at the end of the general session, because expertise means also patient expertise and patient experience. So we would like to add that, if that's possible, to the integration of expertise, the patient expertise.
Okay. Interesting. Now, the fact that you came to the conclusion that we should merge the recommendation sounds like a very Dutch compromise. That's what we always do in this country, is that we also always mix things together and say that's the new solution. But two things came up in your discussion, if I hear it correctly. First of all, extend the field of expertise, so that's very important. And secondly, bring in the patients, their advice, their ideas and what they are looking for. So thank you very much for sharing that with us. I would now like to move to Norbert Lemaire, who we spoke to earlier and who moderated one of the sessions also. So I'm hoping that we can find connection to him. We, of course, heard from him earlier, but we're now trying to look at... Yes, Mr. Lemaire, there you are.
Yes, please, but I'm sorry, I have to close down. I'm in another conference already. I'm sorry.
In conference. Okay, now let's hope that Mr. Lemaire is already in his next conference bringing forward the ideas that we are discussing today, and that he can also, by the end of today, claim some solutions to the problems that we saw, and that he's taken it a step further. The third person and final person I would like to go to is Fiona Loud. Fiona Loud is the Policy Director at Kidney Care UK, and she's chair of the UK Renal Registry Patient Council, and she also moderated one of the sessions. And she's the vice chair at the local Kidney Patients Association at Lister Hospital. I'm hoping that she's with us either with sound or also with camera to hear what happened in her session. But it looks like we don't have connection with her. So I'm afraid we'll just have to skip that. But what we then can do, maybe whilst we're waiting for her, is see if we can find now the total results of all the sessions, because we've asked all the groups to make a rank the 9 recommendations into your top 3, and people have been working very hard here behind the scene to add up all these results, and then maybe they can show us now what then the total result is. So if there is a clear winner. Now, there is. What is very interesting for me to see is that it's impossible for me to read it from here. So maybe I can also get it on another screen so I can actually read out what the result is. It would be nice if yes, it's here on the big screen. What I will do is I will just move a little bit towards there. And the most popular one is EU research money based on disease burden. So basically, most of you say that the most important need is the money first. Because if we have ambition, if we want to do research, we need money from the European Union, so that will be the first thing to seek for. Then in the second position, we can see that go for an inspiring joint goal with participants to fulfill sub-goals. So that really relates, for example, to what Clemens van Bitterswijk was saying, that you can have, of course, your big goal. You want your man on the moon, but in order to get people to run and to actually go find that man on the moon, well, not find the man on the moon, but to help you with that, you have to formulate sub-goals. So that's very popular as well. And the third one is focus on more cash, more money, I should say, for product development. Now, very interesting to see this. These are the results, how you voted. I'm sure that tomorrow, when you receive all the links and a summary and a link to all the videos, that then this will be distributed as well, so that you know that when a whole group of international people with knowledge on this topic looked at this, this was the top 3 they came up with. Now, Tom Oostrom from the Dutch Kidney Foundation, the general manager, is this what you expected as a result, or are you surprised?
No, I think that the speakers, they formulated good recommendations, because what you see is that more recommendations are, or the group said these are good recommendations. It's not a big difference between those recommendations. That's good. I find very interesting that the winner, we could say, is the one that the EU would budget to the economic burden of diseases. Yeah. And that would be very interesting if the EU would do that, because that would mean that there should be more money for kidney research and innovation. So I like that one. I think it's also a kind of lobby goal for the future.
Yeah, I can imagine that it sounds very logical, because if you can prove to the EU what the cost burden is, then there is, apart from all the emotional and personal reasons why you should do this, there is an economic reason why we should put more money into research.
Exactly, and it fits very well in the new policy of the EU. The new policy is very much based on societal challenges. And that's exactly what they want. What does it mean for their citizens? Yeah. What does it mean for not only medical reasons, but also what does it do for the cost, for the economy, for your personal life, your social life? So I think that in that ranking, kidney disease would be high on the top. And I think that was also the message of the speakers today. Yeah.
Yeah, and then the second position was given to finding that inspiring goal and also finding the sub-goals. That can really, well, sort of fund the main goal and make sure that other people will become enthusiastic. Yeah, that's a kind of definition of lobby, I think. Because first you have to define an inspiring goal where you go for. I think Clemens van Blitzwijk, he always calls it the moonshot strategy. You have to go for the moonshot. But in the meantime, people who are part of that consortium, they have their own goals, their own interests of their companies or organizations. You have to think about their interests also. And if you can align all these different interests, then you are making the difference, I think. Yeah. Well, if we're now coming to the end of today's session, what would be the next step? Because one of the main goals, like you said earlier, was to inspire people to form a group to get this train going. Hopefully we've done so today with today's program, with a lot of people watching from around the world. What would be the next step? I think a few steps. I'm really, I was thrilled by the video we saw from Hilde Voutmans. She's the chair of the MEC group. She was very convincing in what she wants to strive for. And she can help us with this lobby. We have an appointment with the MEC group the end of June. So we hope to discuss it further with them. Yeah. The second thing I want to say is that every attendee that was in this webinar gets an email tomorrow. So you can have a kind of compilation of this webinar, and you can also look it back if you want. But I want, and that's my third point, I want to ask people or the attendees who is willing to pay more time on this lobby in the coming years. So we need from a group of people an intense but also a long commitment to go for this goal, because we all recognize that kidney patients deserve a better life. Yeah. And we also see that we can only do this together. So it should be a working group of patients, nephrologists, researchers, policymakers. I would like to form a European group. And finally, I would like to connect to the group where Murray was talking about, Murray Sheldon, that there will be a world consortium on this item. So in my ideal situation, there is a world consortium which consists of groups in the United States, Europe, Asia, and then we can make the difference for all the kidney patients worldwide. Yes. So you have the American initiative. You're now hoping to start the European initiative, where you're looking for representatives from across Europe, from the different stakeholders, patients, nephrologists, researchers, other important stakeholders, to form a group that can sort of start the European movement and then link it to the American one and to the Asian one. Exactly. To start. And I think what we can learn from the United States is always think that the patient's voice is the central voice. Start with the patient's voice. Yeah. And you're saying that how people can assign to this is tomorrow, when they get the recap of today, they can send you an email or can send to someone else an email saying, I am willing to put time and effort into this initiative for a longer period to get this train going. Yeah, the last thing is also important, because as you also know, I think lobby takes time. Yeah. And those are every time small steps. So we want an intense commitment, but also a long commitment.
And I think then we can make steps for the kidney patient. And it would be great if this would be the starting point for that, for that time. So it takes years, and then maybe we could also have influence on the new framework for research innovation in Europe. That's very important. So it's not that we think, well, now we start with a working group, maybe next year we are successful. It really takes time.
Yes, because that really is what we learned, for example, from Ms. Popkova, who was saying the whole complex system that you have to work with and you have to put effort in, and you're basically playing chess on 6, 7 boards at the same time. And every board is as complex as a real chess game, and you have to link them together.
Yeah, and we have to know what is happening in Europe. You have to connect to them,
And you have to go to find timing and the right protagonist, well, the whole list that she was saying. And you're basically looking for the international representatives to sign up for this and to get the train moving.
Exactly.
Well, thank you very much. Thank you for organizing this and taking the initiative on behalf of all the people watching this. And thank you for being with us today, for watching. And I think in conclusion that we are all striving for the same thing. I believe that you're not watching this without any knowledge on beforehand. You're already interested and you're already striving for a better life for people with chronic kidney disease. And we're now trying to form a coalition of the willing, the able, and the people with knowledge to get this going. We hope that you will join. Thank you again for watching, and a good night, good morning, good afternoon, whatever time it is in your part of the world. Thanks for watching, and goodbye.